Female Sexual Dysfunction by Dr. Jennifer Landa. Dr. Landa is one of the country's leading experts on women's health and hormone therapy. Dr. Landa is Chief Medical Officer of BodyLogicMD and Medical Director of BodyLogicMD of Orlando. She practices anti-aging and integrative medicine and dedicates her practice to bioidentical hormone therapy, customized nutrition, and fitness programs. As Chief Medical Officer, Dr. Landa is the voice of BodyLogicMD and is also responsible for the training and education standards of all BodyLogicMD physicians across the country. Maestro, hit it.
For my love, too sexy for my love, love's going to leave.
Ready? It's early morning, but I want to see everybody come on, stand up, and let's clap a little bit. A little energy in the room. You know, it's tough to do the early morning lecture, so I had to do something to make it a little fun, and we're talking about sex, right? I'm so glad to see such a full room this morning, so many people who want to talk about sex. Awesome. I got somebody doing jumping jacks out there. Awesome. Woo! I love to get some energy going in the room. This is great. All right, guys. Thanks, Stacy. Thank you, everybody, for playing. Love to get a little energy going. So, female sexual dysfunction, they haven't really talked about that much on these stages, so I'm really excited to get a chance to talk to you guys about it today. But I want to tell you, just like Andy said, mine is going to be pretty rapid fire too. I've got a lot more slides probably than we can actually get to in a really detailed way, but I wanted you to at least have the slides because I know you all have that to take home. So if I can, I have a clicker somewhere, right? All right, so let's see. All right, so clinical case studies. So I talk a lot clinically, and the reason is I did the fellowship a long time ago. I'm an advanced fellow, done lots of fellowship modules, and I love the fellowship, and I think it's the greatest training you can get in functional medicine, integrative medicine. But one of the things that I find a lot as Chief Medical Officer of BodyLogicMD, I have doctors who come to me for training, and a lot of them through a few modules of the fellowship, or they've taken the first 5 modules, and they've got a lot of great information, awesome biochemistry. We understand the background of why we should be doing what we should be doing and what the evidence looks like. But a lot of people don't feel like they really have the tools that they need Monday morning in the office when they see patients to really understand what to actually do, what to put in practice. So I hope today to give you some clinical pearls. We're going to go over some of the causes of female sexual dysfunction, and we're going to talk about some case studies and how I've been able to help some women in my practice over the years. So I am an OBGYN. That was my original training, board certified in OBGYN. But this whole sexual dysfunction thing was pretty personal to me, actually. A little bit embarrassing to talk about, but personally, and I tell you this because I think it's important that you know why I'm so passionate about this subject. When I was 28 years old, I found myself having absolutely no sex drive. And that's not supposed to happen at 28 years old, especially when you've only been married a couple of years. And it was devastating to me, but I think even more devastating was the fact that I was actually an OBGYN resident at the time. And I actually had no idea at all how to help myself. How many people in the room are OBGYNs? Oh, we've got a lot of you. Good, great. So how many of you think you received really good training on how to help a woman with low libido? That's what I figured. No hands go up. How many of you wish you had that kind of training? Yeah, exactly. Because how many of you see tons of patients in your practice, even if you're not OBGYNs, how many people see patients out there, women who complain of low libido? Yes, the entire room, right. So unfortunately, in conventional medicine, we really just don't receive a lot of training. So that sort of sent me on a 15-year mission to try to figure out for myself and for my patients how to treat this problem. And there are good answers out there, there really are. And I've been honored to be able to help hundreds of women, and by training other doctors like you, thousands of women. So thank you very much for being here and being excited about helping women with low libido. So sexual dysfunction, the human sexual response cycle, everybody knows the Masters and Johnson's model, right? It's pretty linear. We have the excitement, plateau, orgasm, resolution. And how many people, is this the model that everybody pretty much knows? Show of hands. Yeah? Okay, good. And how many people feel like this is exactly right on the way it works for males? Raise your hands if you think so. No? Nobody thinks that's the way it works for men? Come on, you guys. We got up and got the blood flow going so you could raise your hand a little bit. I know you're in better shape than that. All right, so I think most people think that this is the way it goes for males. And how many of us think this is the way it goes for females? Show of hands. Okay, so a fair amount of people think so. This is actually, this was actually brought forward by Rosemary Basson. This is the newer version of the female sexual response cycle, and this really seems to be a lot more on target with the way women experience sexuality. So instead of that model that goes just from the desire to the arousal to the excitement orgasm plateau, women, as men, the men in the room will probably tell you, we are a lot more complicated. So we have a lot more inputs into the thing, and it's not just this curve type of thing, but it's a cycle. And women can enter the cycle anywhere in the cycle. So a lot of women, the female response cycle, it's nice that that's what she called it, because what they've really talked about is the fact that women tend to be more responsive. You know, I find a lot of my patients and I see a lot of couples now, because I do see men in my practice too, and I find there are a lot of couples who come in and they're concerned about the fact that the woman doesn't automatically right away feel like this, you know, she's not sitting around just going, oh my, I'm ready, you know, and people get frustrated with that. But women's sexual response tends to be once you get past what I call the phase of urge to merge. You know, when you're in your young 20s, having sex is like a biological imperative, right? That's what we're all here for. We're all here to reproduce, procreate. And so it's like a drive. It's like sleep. It's like eating, sex, right? But once we get into our 30s, the hormones start to drop, everything that starts to happen with age, it becomes more of a responsive thing for a lot of women. And a lot of women are frustrated by that, or maybe just have unrealistic expectations. So what you really need to teach women to do is to figure out how to evoke a response, basically, and how to get their partner to evoke that response. And a big part of that is the emotional intimacy, right? For a show of hands in the room for women, if you're not too embarrassed, if you're pissed off at your partner, how likely is it that he's gonna get some that night? All right, nobody raised their hand. Exactly, that's the bottom line. When we're angry, when women don't feel close to you, we don't want to have sex. But the really hard part of that is men, how do they feel close? They want to have sex, right? That's what increases the intimacy. So you wind up with these couples in these negative cycles, but they really need to kind of meet each other and realize that it's just so different for men and women. And that's this Basson model. So that's sort of some of the things, the highlights up there of what we just went through. One of the other things that it said on that last slide that I just want to make that point is that with women, you know, men are very goal-oriented, you know, football, soccer, but for us, it's not as goal-oriented. It doesn't necessarily have to end in orgasm for a woman to have a sexually satisfying experience. And I know I'm not telling any ladies in the room anything they don't know, and I know there are a lot of educated men here as well who I'm sure know that, but at the same time, something that I think is really important to bring out in a lecture about this. So the reasons for sexual dysfunction in female patients, or FSD as we call female sexual dysfunction. So there's decreased libido, right? That can be hormone issues, that can be stress issues, and a lot of other issues that we're gonna go through as well. Dyspareunia, so that's pain with sex that a lot of us gynecologists deal with. And the most common thing that people think about is atrophy, but another one that I really wanna bring to the fore is vaginismus. So sometimes you give a woman all the estrogen, vaginal estrogen, and every trick in the book that you can think of, and she still has painful sex. Well, one of the things that you might want to try to differentiate from when you're doing their history is, does she have painful sex that's right at the introitus, or, you know, and does she still have dryness and things like that, or is her pain deeper? Because when you think about it, the vagina is made of all muscle, right? It's all muscle all the way around. So women get this, when they go through, especially when they have a long period of atrophy causing dyspareunia, they wind up having this involuntary contraction of all the vaginal muscles. And then basically, even if you've fixed their atrophy, you haven't fixed their vaginismus, this involuntary contraction of muscles. So the minute she sees anything coming at her, she's involuntarily contracting. And you have to get a lot of those women through that by recommending things like vaginal dilators and to go really slow and easy, but also explaining it to them that this is a muscular thing. And then of course, as you tense a muscle more and more, what happens to it? It gets sore, right? So then anytime she experiences penetration, she's gonna feel that discomfort because she's not able to relax her muscles. So there's a lot more going on there than just atrophy. There's vulvodynia, there's all kinds of things that we can talk about, not today because we don't have so much time. And of course there's relationship issues. Relationship issues and emotional factors, depression, anxiety, things like that. So female sexual dysfunction is defined as a group of disorders that may include the low desire, reduced lubrication, decreased ability to achieve orgasm, and sexual pain disorders. So it's defined according to the, it came out strange, DSM. For some reason, my computer did something weird with these things, but it was the DSM-4, the psychiatric manual. And this is how they actually define the hypoactive sexual desire disorder that some of you may have heard about. And that can be lifelong or secondary or situational. I included this in here just so that you have it. This is one of the screening tests, one of the screening tools that you can use in your practice. And so for those of you who want to think about the pathophysiology, there's the sexual stimulation, and a lot of us know that leads to the release of nitric oxide, which leads to the activation of cGMP, and that gives you that local excitation response. I think it's really interesting in the literature, there's actually a lot of evidence for the fact that estrogen and testosterone can both promote the expression of nitric oxide synthetase. So when you are giving your patients vaginal estrogen and also vaginal testosterone, how many people in the room use vaginal testosterone? Good, a fair amount of you, great. So there are definitely receptors in the vagina for testosterone, and a lot of women do better if they're not doing well on vaginal estrogen when you add vaginal testosterone to the mix. So as far as neurotransmitter effects, there's a ton of research that shows us that dopamine is essential for sexual function, but serotonin is extremely inhibitory. So the balance between the two is very important. So when you're looking at women with sexual dysfunction, you may want to look at neurotransmitters. You may want to look at what you can do to enhance dopamine through different supplements that you might want to give them. Other parts of the system that are excitatory, oxytocin, we're starting to hear a lot about that nowadays. I always encourage my patients to enhance their natural release of oxytocin, hugging, lying naked skin to skin, all kinds of things that we can do, massage, even nipple stimulation to increase the flow of oxytocin. And of course, you can dispense oxytocin. How many people in the room use oxytocin for sexual dysfunction? Good, we've got a lot of educated people in here about sexual dysfunction. How many people are practicing sexual dysfunction regularly in their practice? Okay, good, great, good. I hope we can get everybody in the room to raise their hands by the end of this year. I had forgotten to mention, I wanted to tell you right off the bat, this lecture is kind of just a little introduction for what we're introducing, which is a certificate program in sexual health for women and for men. So it's going to be a 4-module program, and it's going to be a certificate program, and it's starting in November in Atlanta. So we hope to see anybody who's interested in learning more about sexual dysfunction, hopefully all of you in this room in November, and tell your friends if they want to learn more about sex. We're going to go very deep into way more than just female sexual dysfunction, male sexual dysfunction. We're going to learn about injectables for ED and all kinds of exciting, great stuff. So there's actually a lot of functional MRI study that goes on in the field of sexual health, and they've actually shown changes in the central nervous system of women who have hypoactive sexual desire disorder. But it's hard to tell what came first, the chicken or the egg. Did they have the functional MRI changes? Did they have the CNS changes prior to getting HSDD? Or did the changes come about as part of HSDD? It's interesting. I won't go through all the changes that they've noticed, but one area that they've noticed a change in is self-monitoring behavior, that these women tend to have a much stronger sense of self-monitoring. So did that come up because they had HSDD, or is that part of the reason they got HSDD, because they're so busy kind of watching themselves and, am I getting turned on, am I going to have an orgasm, what's going on here? But they have a really strong reaction in that area as compared to women who don't have HSDD. So medical problems. We all know there's medical problems that can be associated with female sexual desire disorder and hypoactive sexual desire disorder. And there's genital structural issues. So we talked a little bit about dyspareunia, and we talked a little bit about vaginismus. For those of you who don't know what vulvodynia is, it's basically vulvar pain syndrome. Vulvar pain syndrome, I'm going to have actually a specialist in this area lecture to us in the certificate program. So we'll learn all about it. But it's multifactorial, basically. We don't have one quick answer for it. And the answer definitely isn't to just apply a topical steroid. So many docs turn to that, unfortunately. And what that does over time is that's going to thin the skin. And that's actually going to make her condition worse over time. So you may want to rely on it for very, very short term, but you definitely don't want to use that for long term. So what's the pathophysiology of that? We don't know. There seems to be a lot of post-candidal issues with women, so definitely taking care of candidiasis, which gynecologists do in a very traditional way, and luckily all of you integrative and functional medicine practitioners take care of the whole body, so we address it in a much more systemic, holistic way, which is great because hopefully you're going to keep these women from ever developing vulvodynia. Lichen sclerosis is a condition where women form plaques on the vaginal tissue and the vulvar tissue, and it can even be a precancerous condition. Of course, you should refer it to your gynecologist to treat, but you can detect it with like white plaquing, so it's more severe usually than your typical atrophy that you would see. And then the vaginismus we talked about, and of course women with urinary problems are not at all excited to have sex, and women whose bladder's falling out when they have sex, that can certainly cause a big problem for them. Emotional issues, that's another one of those chicken and egg things. Do the emotional issues cause the HSDD? Or women with HSDD very frequently will suffer mental health issues because it really is a devastating condition to a lot of women. And general emotional health obviously does affect the libido. So if women have a low self-esteem, emotional instability, so the bottom line here is know what you're treating. A woman might come into you, and I've had lots of patients like this week after week complaining of their low libido because that, for whatever reason, is the symptom that they're focused on. But make sure you take a good mental health history, because if they're depressed, you're never going to be able to fix their female sexual dysfunction by just giving them hormones or whatever it is that you think you should do for it if they're depressed or if they have severe anxiety and things like that. And then that all ties in hormonally, right? I don't talk a lot about it in this talk, but I'm going to just sort of throw it out there. A lot of you are here and studying about adrenal issues. Adrenal issues are probably one of the number one things I see in all of my patients. So I would say more than 95% of my patients have adrenal issues. Do a lot of you feel that way as well? Show of hands. Who has? Yes, everybody. Yes, and it all really starts there. I really believe, I'm a gynecologist and I treat, of course, a lot with estrogen, progesterone, testosterone. But if I don't address the adrenals, I'm just kind of trying to fill up a bucket that has a hole in the bottom. There's just no way I'm ever going to get those patients to where I want to get them to unless I address their adrenal health. And that's all tied in with their mental health, right? Because they're going to have so many symptoms that are going to look like a mental health disorder if they have adrenal problems. So hormones and sexual dysfunction. Libido is not just about testosterone deficiency. There are a lot of doctors who, if they are replacing testosterone, they're just replacing testosterone. But like I was just saying just now with the adrenals, you're really not going to get anywhere for the long haul if you do that. You might have a couple of good weeks, but giving an adrenally deficient patient testosterone, in my opinion, it's like pressing on the gas in a car that basically has, an eighth of a tank left. So you get a little bit of a rev, but then they actually start to feel worse than they ever felt before. So you want to be careful with that, but it also can be an issue of low estrogen, low progesterone, excess cortisol, low cortisol. Both of them can cause that. So you've got a lot of different issues hormonally to look at when you're looking at women with female sexual dysfunction. So other medications. So the PDE5 inhibitors, we were all excited when they worked so well for men. We were hoping they would work well for women. Well, everybody knows pretty much the party line is they don't work for women. But you know what? That's actually not true. And I want to tell you, I do have certain patient populations that I do treat successfully with PDE5 inhibitors. Women who have arousal disorders. So what I mean by that is women who don't lubricate well, women who have really poor sensation, especially I find women who are post-hysterectomy. Even if they had ovarian-sparing surgery, I find a lot of times it seems like there's enough of a disruption in the blood flow and in the nerves, the local nerves, that they get this decrease of sensation. And if you're able to give them a little bit, and even some women, I have some women in my practice who haven't had hysterectomy who have great results with a very small dose of PDE5 inhibitors. And whether that's a pharmacologic PDE5 inhibitor or an herbal PDE5 inhibitor, because there are lots of those. Horny goatweed, for example, is a great PDE5 inhibitor that you can use. I know it's a very funny name. Unfortunately, they really haven't come out with any. Obviously, there is no magic pill for female sexual dysfunction. The magic pill that they tried to get approved for a little while was this flibanserin. It really wasn't shown to do much more than placebo. So herbs and supplements, I was just mentioning horny goatweed. A lot of the herbs and supplements out there, I think that's sorry if that was a brand name. I have nothing to do with this company. It just seems to work well. I'm looking at the Arginmax, sorry. So L-arginine is great because it increases that nitric oxide, right? So we talked about before how the pathophysiology of female sexual dysfunction includes the nitric oxide pathway. And a lot of sexuality, and especially the arousal disorders that we were just talking about, when women have low lubrication, especially even despite the fact that you've given them estrogen, it's all about blood flow, right? Because the female tissues are the same embryologically as the male tissues. We need to get the blood flowing and get that erectile tissue going, because that's actually what the lubrication is. A lot of people don't realize it's actually like an ultrafiltrate of serum. So it's getting the blood flowing through the tissues that actually causes women to have the lubrication. So if you don't have the blood flow, you're not going to have lubrication. So L-arginine is a great supplement to get that going. Scream cream that some of you might use from local compounding pharmacies have things in it like aminophylline, menthol, and those can be stimulating for some women. Ginseng, you know, it's been used over thousands of years in China, obviously. It's great for energy, but it's also great for vitality, sexuality. A lot of women get good results from that. Ginkgo, Damiana. All of those work really well. B-complex, I think, is one of the most important basics that we can give our patients when we're trying to balance out estrogen and progesterone. So in all of your PMS-type patients, patients on birth control pills, we'll talk about that even a little bit more in a minute, but patients on birth control pills become very deficient in B vitamins, and that enhances that imbalance between estrogen and progesterone even more. And so the horny goatweed, we talked about that supposedly there really was a goat herder who noticed that his goats did actually mate more when they fed on a field with this herb in it. That's how the story goes at any rate. And some South American, Amazonian herbs and supplements there. So I said I'd work in some cases. We're going to have to start going even a little faster because I've been kind of taking my time. So I've got a 55-year-old woman in my practice who her moods were fine on Zoloft, her energy good, but she was having terrible vaginal dryness, excruciating pain, tried Premarin, helped just a little bit. Maternal history of breast cancer, so of course she was concerned about HRT. She has vaginal atrophy. She's afraid to use what she'd been given for it. She'd been given something traditional, conventional by her gynecologist. She sleeps okay, not as well as she used to. Basically negative past history. Zoloft was the only medication, only rarely has alcohol. Works as a military trainer, doesn't have really super high stress or anything like that. So I go through a lot in this case, which we're really not going to have, and I have a few cases in here, which we're really not going to have time to go through in a lot of detail, and you can study these in your notes. But basically what we're seeing here is, so she's got kind of just a borderline low estrogen and borderline low progesterone, but the testosterone is really pretty awful, right? I don't know if you know, unfortunately I don't have the normal values here for this lab, but her testosterone, it was 12 to 55, I believe was the normal range for testosterone, and that was for all ages. So this woman certainly has a low testosterone, and she has the atrophy, dyspareunia, whole sexual pain thing going on. So vaginal estrogen, possibly testosterone, like I'd mentioned earlier, the vaginal dilators as well. She had a high hemoglobin A1C. So pointing out the fact that high hemoglobin A1C, diabetics, they tend to really have those issues with decreased sensitivity, decreased arousal, because they have the microvascular damage. So those patients, you really have to pay a lot of attention to blood flow and getting that going. And the biggest red flag, of course, in this whole case to me is the Zoloft. So to highlight the interaction between depression and desire disorder, but also antidepressants and medications in general, and what they do for female sexual dysfunction, or what they do to promote female sexual dysfunction, unfortunately. It's amazing how many patients I've gotten off of their SSRIs who've told me, I can't believe it, I can actually have an orgasm again. I can't believe it, I actually want to have sex again. And I've been walking around on Zoloft for 10 years and had no idea that the reason I didn't want to have sex anymore was because of this Zoloft. So of course, this imbalance between serotonin and dopamine that we talked about earlier is one of the biggest problems here. So hormonal contraception, that one's near and dear to my heart because I told you I lost my libido when I was 28. Well, that was a big part of the reason why. I'd been on birth control pills for many years. And I was doing okay. I was holding my own on it for many, many years. But what happened was then I became an OBGYN resident. Welcome adrenal fatigue, right? So what happens is you get that cortisol steal phenomenon, the pregnenolone steal phenomenon. So basically, all of my pregnenolone was going to make cortisol to keep up with my stress, and none of it was going to make progesterone or testosterone. I find women like this in my practice every day, all ages. To me, this is one of the most common reasons that you have women with no libido in their practice. Stress is the biggest sex killer, but it's not only obviously because of just the stress, I'm too overwhelmed, but it's actually because of the changes in the hormonal milieu. But back to birth control pills and any kind of oral estrogen is going to increase sex hormone binding globulin. So it's going to bind up all your free testosterone. And then there's other types of hormonal contraception. And the Mirena IUD, a lot of gynecologists will tell their patients, oh, the progestin is just right there in the uterus. It's not systemic at all. Well, digging a lot deeper on that one, I found that 30 to 50% of women can become anovulatory on Mirenas. But they don't realize it because you've thinned out their uterine lining so much, and you tell them that the reason they're not bleeding is because they have no uterine lining. But sometimes you do hormonal testing on those patients, and they appear menopausal, because basically they're not ovulating. So it's kind of just like the Depo-Provera thing. You know, we're increasing their risk of osteoporosis, because they're not secreting any estrogen, and of course you're killing their libido. So psychiatric drugs, anti-seizure drugs, lots of other different types of drugs that are used for FSD. So what did I do with this patient? So of course I gave her some progesterone, testosterone, DHEA, and I did give her a vaginal cream. This is kind of maybe a typical cocktail that I may use for a vaginal cream. I use the E3, I use a small amount of E2 because of course it's stronger. And I use about 1 milligram of testosterone, and I have them apply. It's very important to tell your patients, I think, that they get the vaginal cream with this applicator, and most of them, of course, will use the applicator like the good people they're supposed to. I see one of the pharmacists I know sitting in the front row, and they cringe when I say this, but I tell them to just throw that vaginal applicator out, because that thing is not going to be your friend. That's not going to help you. What it's going to do, number one, is your patient's going to come back and complain to you. That stuff's messy. It's all over. Even if you're only giving them a half an ml or 1 ml, so that's a lot smaller than the conventional therapies, which are a gram, which is terrible. Women hate that. But they're also just wasting it because they're not rubbing it in. It's just coming out on their underwear. So I really recommend that they take half the dose that you give them, which is for me usually an ml. I have them put half of the dose deep inside the vagina, really rub it around if they're willing to do this, or their partner for 30 seconds. Their partner obviously wearing a glove would be a better idea for the estrogen. So have them rub it deep inside the vagina, and then have them rub it over the clitoris, over the vulva, and especially right at the introitus is the most important part for most women. And they get it when you explain it to them. So put it where it needs to be. So I did recommend some supplements for her, recommended some dietary changes, and we did wean off the Zoloft. Her vaginal dryness and dyspareunia resolved, her libido improved as a result. So some women, all you have to do is make it feel better, and they want to have more sex. And she did do well because with her moods off of the Zoloft, because she didn't have, as I love to say, she didn't have a Zoloft deficiency. She had a hormone deficiency, so we balanced her hormones and she felt better. So this is another patient who complains of low libido, has PMS symptoms, irritability, anxiety. She's scattered, memory is poor, poor energy. She really doesn't have a very remarkable medical history at all. She does drink a fair amount, 7 to 10 drinks a week. She has huge stress, humongous stress. Her husband lost his job. She's the primary provider, has kids. So she's, of course, on the go a lot, doing fast food, has a poor family history of cardiovascular disease and type 2 diabetes. Basically these labs, what they showed me was she had a borderline high estrogen and pretty low progesterone. So from all these foods she's eating, she's getting xenoestrogens, right? So her levels of estradiol were increased. Levels of progesterone were low. Testosterone was on the floor. But her cortisols were basically through the roof day and night because of this high stress. So what I wanted to highlight with this case is about the stress that I was mentioning before, and about the fact that not only is all of your hormone precursors going to make cortisol, but what's also happening is the cortisol actually interferes with testosterone. It interferes with the way testosterone works. So when you give these women, if you just give them testosterone, you can give them all the testosterone you want, and I've gotten these women, believe me, on occasion, their testosterone levels up way higher than they should have been. Of course, we brought them right down, but they still came in and said, I still have no libido. And the big issue is the cortisol, the big issue is the stress. So like Dr. Heyman was talking about, find the reasons that they have high cortisol, look for the infection, and look for the stress in their lives and everything that's causing it. And of course, she had a lot of impending medical problems as well to take care of. Whoops. So those were my concerns. So just kind of to highlight the fact that emotional factors and well-being are one of the biggest predictors. There's actually some studies that do show that that high cortisol and stress will decrease the expression of endothelial nitric oxide synthetase. So it all works together. So you really have to decrease that stress. So what did I do with her? I gave her some progesterone. I gave her a testosterone pellet, and that was one of the things that I wanted to highlight. I use testosterone pellets in my practice very successfully for women with female sexual dysfunction. They tend to do extremely well. How many people in the room use testosterone pellets? Good, but not enough of you. Testosterone pellets, how many love the testosterone pellets? Yes. So testosterone pellets work extremely well. They work very physiologically, actually. They follow when you have the testosterone, it's a sustained release testosterone. For those of you who don't know what a pellet is, it's a small little pellet, for lack of a better way to explain it. You put it in the area of the hip right here. It's like a 5-minute office procedure, really easy to do with a little local lidocaine. There's a kit with an inserter. It's real simple. And there's plenty of people around the country who are doing trainings and things with pellets. But it's an extremely effective method, and we can deliver testosterone for approximately 4 months with this pellet. So they just have to come in basically 3 times a year for their pellet. I have tons of women who just love their pellet therapy. So if you don't know about it, find out more about it. And we're definitely going to spend time talking about that in the certificate modules. So, of course, this woman, I was telling you about stress. So these are some of the adaptogens that I like to use when women have high stress. I like the ashwagandha. The ashwagandha is great. Ashwagandha slows down your conversion of cortisol to progesterone. So I find it great for women with sexual issues. I find it great for women with high cortisol issues, low energy. Also, for women with hot flashes. This is off the topic, but just kind of like one of my little tricks. Ashwagandha 500 BID can work very well for women with hot flashes because so many times hot flashes are really due to cortisol, not due to low estrogen. So before you keep pouring more and more estrogen into that woman who has hard hot flashes to fix, when you have resistant women, look at the ashwagandha. So I also like the Eleuthero rhodiola. This was one product that all came together. And some L-theanine and some phosphatidylserine. L-theanine is a great amino acid for decreasing cortisol. It works really well for calming. It works really well for obsessive thinking, like your patients who wake up at night and they can't get themselves back to sleep. And it works well to lower cortisol. And you can even give them 200 BID. I'll do that a lot as well if they have anxiety and stuff during the day going on. The phosphatidylserine is also a great nutrient for decreasing cortisol. Serines decrease cortisol. So I give a lot of these patients phosphatidylserine. It also helps with memory, so they're also happy with that. So of course, you really have to emphasize with these people the stress reduction techniques, yoga, decrease alcohol, because alcohol is, of course, an adrenal toxin, and libido enhancing strategies. So we talked about mindfulness. Mindfulness is what I call the secret ingredient of increasing women's libido. I think one of the biggest problems for women is that they aren't able to be right there in the moment. And I think that is when, everybody talks about sex being 98% in the brain. And it really is a huge thing if women cannot be mindful, if they can't be there in the moment. So I tell them to practice that. I tell them to read books like The Power of Now by Eckhart Tolle, all about being in the moment, being present, and really practicing that in their daily lives, looking for sensual experiences anytime, anywhere. A beautiful flower that you see, the smell of the flower, the taste of the food that we eat, the feel of the food on our tongue. So many people of us ignore those sensory experiences every single day. And when we tune into those better every day, we're going to tune into them better with sex. They're going to enjoy sex more. And they really have to learn to be present in the moment, because so many times they're having all these thoughts floating in and out of their heads. Johnny needs soccer cleats tomorrow. What do I have to, I have to get the laundry done. I see women nodding their heads. It's definitely one of those things that women experience. But with practice, I've had a lot of patients in my practice who've been able to do something more like what I call flip the switch. So with practice, they're able to say, okay, this is the time when I want to have sex. I want to be intimate. So I'm going to flip the switch and I'm going to be present right here in this moment. And they do really well with that. And so you need to coach them on that. You need to discuss that with them. So androgen therapy. So I talked a little bit about testosterone pellets. These are just a summary of some of the studies. There have been a ton of studies done on testosterone, although we have no testosterone for women other than the methyl testosterone in estrotest. We have, obviously, when I say no, I meant pharmaceutically. We have lots of compounded options, obviously, and there are great people at the booths out there to tell you all about testosterone pellets, testosterone titurates and troches, and all kinds of great methods. I actually use a lot of injectable testosterone with my patients, in addition to the pellets. So literally, this woman, she loves her testosterone pellets. She's been coming back to me it's been over 5 years now for testosterone pellets. And she just says, but it does so much more than just sex. Testosterone improves energy, memory, mood, libido, self-esteem, self-confidence. They just really feel like they've got their vitality back. They've got it going on. And it improves their relationships when they can improve their libido. So I talked a little bit about mindfulness and being present already. And the book, The Power of Now, if you haven't read it, it's an awesome book. It's a Q&A type of book, so it's really easy to read. I love it, and I encourage people to read it. And people have told me in my practice that it's just changed their lives. Novelty, adventure, challenge, that's one of the biggest things that people need. If you're having sex with the same person in the same way for 2 years, let alone 20 years, it's like if I asked you to eat your favorite food or watch your favorite movie 3 times a week for the next year. Even though it's your absolute favorite, you're going to get tired of it. So that's why people really need to employ new techniques, novelty. I say anything from mild to wild. So it can be anything from bubble bath to massage oil, whatever it is. I actually challenge my patients. I tell them to take the libido challenge. I tell them to schedule 2 date nights a month for at least a few hours. Don't cancel no matter what. Build up the anticipation. Flirt like you used to when you were dating. Get the kids out of the house if you can. I tell people, do a kid swap. If you have a best friend who has 2 kids, take her kids one weekend and have her take your kids the next weekend. And put it on the priority list. Women are great at making lists, but they let themselves and everything about their own self-care and sometimes even their relationship fall to the bottom. So I tell women literally put your husband's name or sex, if nobody looks at your list, whatever, on your list to remind you, because like I said before in the very, very beginning, it's a responsive thing for a lot of women. So if there's no stimulus, there's nothing to evoke the response isn't there. But you can evoke the response by just causing yourself to think about it more often and coaching your patients to do the same thing. Of course, you need them to clear the decks. Basically, make sure that all of their little tasks and to-do lists are all done before they embark on this date. I've had so many of my patients be so creative about this. One of my patients came back in and told me she surprised her husband in the middle of the day and sent him, this is a woman who complained of really low libido, but we got her hormones back in place. I coached her a lot on these things. She came in, she said it was the best. Her husband, she surprised him with a hotel key in the middle of the day, and they sneaked off for a nooner. But the funniest part of the story was he opened the package right in front of, he's a senior engineer, and he opened the package in front of a whole bunch of junior engineers. So now anytime Mike gets a package at work, they're all like, ooh, Mike. So patients can do great with this. They get creative, they have fun. I thank you so much for your time today. If you want to learn more about sexual function, please come to the first module of the Certificate in Sexual Health on November 2nd, and I hope to see you all there in Atlanta. Thank you so much for your attention, everybody.